So I'm Andy Chan, and I'm here to give you a presentation on behavioral health. I'm going to try and make sure I'm sharing my screen with you right now. There we go. I think that's working from the beginning. Is that... Hopefully people can see my screen. And as you can see, maybe from the title is slightly different from the one that's in the agenda, mostly because all the way through, I've been working under the illusion that I was doing a presentation on creating partnerships to address behavioral health issues in housing. And then I looked at the agenda today and said, hang on, that's slightly different from what I've been working on. But anyway, don't worry, because we will be going into a lot of the issues regarding mental health issues and housing, less of the sort of like the deeper background though. So a little background about me. I have a doctorate in political science from the University of Bristol back in jolly old England. I have 20 years of social services background, starting working in homelessness services, and then progressively to more general social services, specifically with low-income housing residents, both for Evergreen Community Healthcare and for the City of Seattle's Aging and Disability Services division, which does general social services and reauthorization of home care for low-income Medicaid recipients. Then I moved to Seattle Housing Authority, where I was a community builder or community organizer for about 3 years before moving over to the Office of Policy and Strategic Initiatives in the Seattle Housing Authority. And I've been there for about 1.5 years working primarily on health issues and our health initiative. And a little bit of context even about the presentation. When I was first asked to do a presentation by the executive director at the Seattle Housing Authority, we were, I think, thinking about a fairy tale story that has subsequently turned into a bit of a drama, and at this point just hoping that it don't turn into a horror story or a French farce. So it's going to be interesting, and a little bit of a case study on addressing, I think, behavioral health issues in a changing landscape. So without further ado, I will try and avoid as many acronyms as I can. I'm usually pretty good at that, but feel free, someone shout at me if I'm using acronyms that you don't understand. Okay, so we are on slide number 2, and if I could just move that. No, I can't move that out of the way. Hopefully you can see more of the screen than I can. But this slide basically says identifying the problem. So what we're basically talking about here is creating partnerships and working with partners in addressing behavioral health issues for low-income residents of public housing authorities, specifically in this case, the Seattle Housing Authority. And, having had my perspective both as a social service provider and working for a public housing authority, it has been pretty clear at various points in time that there are a lot of folks in public housing authorities who really do think that housing authorities are about housing. And I know the name does kind of mostly give it away, but I think there's a more general recognition today than perhaps in earlier decades that that there is more to housing folks with the kind of background of uh, low income, having a low income and coming with mental health problems, with substance use problems, coming from homelessness. There are attendant issues to do with that. Seattle Housing Authority has a pretty long history of working with social service partners, and so certainly a part of the Seattle Housing Authority has recognized that that you can't just put people in housing and let them hope that they will be successful. So for a long time, we have had contracts with social service partners, both with the City of Seattle's Aging and Disability Services, who I used to work for, and more recently with Full Life Care and Neighborhood House. So, addressing both sort of to some degree behavioral health, but also more general social services kind of things, not being able to fill out paperwork, not knowing the resources in the local community, things like that. Certainly there's been a certain amount of resistance still amongst various levels of the staff about providing these kind of services that going beyond providing this platform for people to be successful themselves. But we are moving along the continuum, I think, and it's not a simple one-way progression. It does move backwards and forwards a little bit, but I think we have a general recognition that this is something that is relevant to housing authorities to address. Although Seattle Housing Authority has been working with aging and disability services for over 25 years and Full Life Care for about 10 years, I think it's also important to recognize that we shouldn't rest on our laurels. Just because we have certain kind of services set up, that doesn't mean that everything is can be left to them to do things. There's an insufficient capacity, not enough staff, there's not enough funds, there's things can change as we all start to recognize this year if we didn't before. And so it's not about setting up something and then just renewing and renewing and renewing. When we sort of started thinking about the health initiative in the Seattle Housing Authority, it became clear that behavioral health was one of those issues that kept on coming up. There were continuous reports from staff of unmet needs in challenging behaviors, both in chronic terms, people who have a low acuity problems just constantly, and people who have high acute needs, somebody who's suddenly blowing up and creating a big problem for residents around them. And the quote from the resident that I have there on the right hand side of the screen, it was something that I asked, so what's it like? And it can be as much as just one resident who's having a really bad time can make everybody else's life hell. There's no doubt about that. I'm hoping that I can advance this. Oh, there we go. So when I moved into the policy department, they basically tasked me with looking at the problem of behavioral health needs for SHA. I'm going to start calling us SHA now. One of the first things that had already happened was that we'd already been in a certain degree of discussions with King County, who are the folks who run most of, or are managers of most of the behavioral health services in King County. So their division, the Behavioral Health and Recovery Division, had been talking to us for a while, and this had come from some earlier discussions called the one table discussions, which were actually regarding bringing people together to talk about homelessness more specifically. We already had a data sharing, or we developed a data sharing agreement with them because we wanted to find out more about this situation. And we hoped from that we would get a population level behavioral health enrollment analysis of sorts. And it was actually really, really helpful to do this. We were able to analyze where behavioral health enrolled residents lived in our buildings. And we were able also to find out, again, at a population level, the level of activity there was for behavioral health enrolled residents living in our buildings. And it became quite clear early on. I should point out that we have a number of different portfolios in the Housing Authority, and some of them are more focused on families. There is, of course, the Housing Choice Vouchers folks. But from this analysis in this partnership with the Behavioural Health and Recovery Division, it was determined that our low-income public housing, which houses predominantly single adults, had a much, much higher percentage of behavioural health enrolled people than any of the other portfolios that we have. And the difference is stark in the sense that 22% of our low-income public housing residents were currently enrolled in behavioural health services, whereas in all the other portfolios that the SHA has, that averaged out at 5% per community. And even more interesting and significant, I think, than that was they did some further background analysis and uncovered that 80% of the residents of our low-income public housing buildings had a lifetime enrollment. That is, at some point in time in their life up to this point, they had been involved in some kind of behavioral health services that was run by the county. So that was really surprising. It certainly surprised me that it was that high, the 80% number. So that was a starting point for our analysis of what the problem is for SHA. The next part was that I engaged in what was termed the behavioral health needs analysis. And this was a number of different elements to get to understand what the behavioral health issue for SHA was. It involved interviewing staff and social service providers for some quantitative data. And one of the interesting things that we found out from that study was that the biggest behavior challenge for our staff, that was both the Housing Authority property management staff and for our social service providers, was that substance use, troubling substance use, was the primary challenging behavior in some of our hottest communities. Other things including things like non-threatening conflicts between residents. That was also a pretty big one, but certainly substance use was the largest one. We also did some interviewing residents for some qualitative data to flesh out how their experience was in the buildings and what kind of quality of life they were experiencing. We also looked at the use of healthcare utilization data through our data sharing agreement with United Healthcare. And that told us whether residents with challenging behaviours were also high utilisers of health services in general. And I guess fairly unsurprisingly, yes, they are. Twice as many behavioural health enrolled residents of our low-income public housing had used the emergency department in the last year, and that was about 45% versus 23% of the general low-income public housing population for SHA. We were also with our partnership, excuse me, in our partnership with the City of Seattle and a data sharing agreement with them, able to have them look again at a population level at PRISM data. And PRISM is the Predictive Risk Intelligence System. I think that's right. That is used by Washington State's DSHS. It's a predictive modeling tool for high risk Medicaid clients. I won't go into that in too much detail, but in this context, basically it told us what health services who uses what health services to determine who would qualify for something such as foundational community supports, which is, if you don't know, a Medicaid transformation initiative for supportive housing. Now, one of the good things about foundational community supports is that it's definitely an effort to bring medical services into the arena of social determinants of health, in the sense that it works for folks both in the supportive housing arena and also in supported employment. One of the issues, and there's a couple of issues, I won't get into them, but one of the issues with foundational community supports is that it's, because it is Medicaid based, there are dual qualifying criteria, which means that someone has to have both an assessed health need and a risk factor. And so it can be quite difficult, especially for a housing authority, to know who might be qualified for that, because we wouldn't necessarily know the assessed health needs. But in partnering with Aging and Disability Services, who do have access to some of this data, we were able to sort of like work with them to address some of the behavioral health needs. Okay, so moving on to, I mean, that basically gave us an idea of the problem, where we were at internally, what some of the problems were for the residents, what were the particular challenging behaviours, and who might qualify for some of the statutory services that are already out there. But there is not just a problem that is for the housing authority. There is also the external problem, and here this is a bit flippant, but what I have on the screen is, hello, can you come and talk to your client? Hello. And I'm just saying that from the perspective both of our property management and from our more general social service providers. And that what I'm trying to say here is that, and this is not across the board, this is not in every situation, this is not referring to every single agency, but quite a lot of the time, with quite a few agencies, in quite a few contexts, our staff, both property management and social service providers, have found it quite difficult to engage the clinical providers of behavioral health out there in the community. And this is hopefully not because those folks don't want to engage with the housing authority, and not because they don't recognize the importance of the social determinants of health and things like that. It's that the system currently, as it stands, is not well set up to encourage the provision of behavioral health services outside of clinics. And this is clearly a bit of a problem. We were finding it a bit of a problem because even, I mean, sort of clinics are great one-stop shops for services. If you take the time to access those services. If you don't take the time to access those services, it's certainly a lot more difficult. And a classic example that we identified fairly quickly was hoarding disorder. A person who has hoarding disorder could go to if they had one, a behavioral health provider, and the behavioral health provider would, unless they were very canny, have almost no idea in many circumstances that someone had a hoarding disorder. You, in many cases, only see that, you know, from going to the place where the person lives or talking to their housing provider, who often is the person who thinks that there is the real problem. So we have, yes, lots and lots of organizations providing Medicaid-funded behavioral health services, but they can sometimes find it, I mean, we can find it quite difficult to identify who they were. It can be difficult to reach and or to communicate with them sometimes. Again, sort of HIPAA makes it very difficult sometimes for them to communicate with us. And it can be very difficult for them to come and see non-compliant clients or clients with escalating behaviors. Things aren't set up very well for that. So I want to give you a little bit of context in regarding the behavioral health landscape in King County, sort of in the run-up to 2020. In 2017, there was a Medicaid, Washington State decided to do the Medicaid waiver transformation 1115. And part of that was, in terms of behavioral health, a 2019 behavioral health integration in King County. So that was where basically there was a concern that there was not being a whole person approach to medicine. So the managed care organizations in King County would now have to be the providers of behavioral health services, or at least they should have to fund on an equal footing behavioral health services. Now, that has happened across all of Washington State, to my understanding at this point. In King County, things turned out to be slightly different from a lot of other places in Washington State, in the sense that in the old system, King County was involved as the behavioral health organization middleman, and that was brought over into the new system. So the excuse me, the managed care organizations don't contract directly with behavioral health providing agencies. They contract with King County, and then King County does all the kind of like the individual work with contracting with the behavioral health agencies. So that's one aspect of the behavioral health landscape for general behavioral health services. So this is all the agencies with their case management and therapy and doctors and medication management provided through Medicaid. The behavioral health agencies themselves, organizations, so what do they do? Yes, they provide clinic services, basically. It's essentially one-stop shopping, where a client signs up to be with one of these agencies. They get tiered at a certain level, so they're allowed to be provided a certain amount of services, and those services, as I said, medication management, case management, their psychiatrist and or therapist, if they're in that track, are typically provided in the clinic. And the payment system that they have, and was basically something of a holdover from the old system, is basically my understanding, and I don't have an in-depth understanding, but from the people that I've talked to, this payment system definitely emphasizes sort of this clinic approach, and as I said, for folks who are going to the clinic, this is great that you have all these services, and potentially day treatment, day groups, all in a single place. It's great. You don't have to go to all these different places, but this system does disincentivize home visit for the folks who are uh, let's call them less compliant with services, or who fall off. I mean, sort of case managers may be encouraged to keep in contact with folks out in the community, but it is so much more difficult, so much more time consuming for them to do that, that as I said, that this is the situation that our service providers and our property management were finding themselves in that they often could not get the behavioral health providers to come out to the buildings to help their clients. And that is all essentially a matter of money. When I have talked to behavioral health providers, excuse me, I haven't had a single one say, "Oh, we really just want to do services in the clinics. We don't want to come out." Everybody I've talked to, programmatically speaking, says we'd love to come out and see clients in the home, but we cannot get the reimbursement that allows this to happen. That would require a much smaller caseload than the case managers are holding right now. So it's just at this point not possible to do. So let's move on to the emergency response system. So in King County, there's a number of different elements to the emergency response system. One of the main ones is the designated crisis responders, who used to be known as the county designated mental health professionals. They respond to crises, fairly acute crises, ones where there is a fairly imminent threat of harm to self or others, or grave disablement by some mental health or substance use issues, such as not caring for basic needs, having no access to food, things like that. And the designated crisis responders can initiate involuntary detention for folks who are significantly disabled by one of those things, and they can be detained for up to 72 hours for an initial evaluation before seeing a judge. And excuse me, with the designated crisis responders, anyone, you, I, anybody can make a referral, make a call into them. Then in King County, there is also the mobile crisis team, and this is a team that I believe is run by the Downtown Emergency Service Centre folk, to respond to people who are in a slightly less acute mental health or substance use crisis. So they're not necessarily an imminent threat of harm to themselves or others, but they're definitely going through a significant crisis. And one of the important issues with this team, the mobile crisis team, is that they are not a direct referral from individuals kind of service. Typically, they are referred by professionals such as Emergency Services 911, Seattle Police Department, or the Fire Department, or by Crisis Connection. So someone can call in the 211 number and get them to make some kind of determination. But they're covering a fairly broad swathe in the county with this. And then one of the other elements to the behavioral health landscape in King County was the MID funding, and that is, I'm probably going to butcher this, mental illness and drug dependency funding. This was a sales tax in King County, or is a sales tax in King County, which has supported numerous behavioral health related initiatives across the county. Some really interesting stuff, including preventive and early intervention screening for substance use disorder in emergency departments and juvenile justice system, crisis intervention training for first responders, the law enforcement assisted diversion program, which gets some people out of the criminal justice system and into a more appropriate treatment system, drug courts, recovery and re-entry to housing after homelessness and or incarceration. So they have had a pretty broad remit to fund some really interesting and helpful behavioral health related services. And so moving on to how the Seattle Housing Authority has had it by itself, not by itself, but sort of how it had responded further to the issues of behavioral health for our residents. So as I had previously mentioned, we'd already made a connection with King County's Behavioral Health and Recovery Division, and we were sort of having discussions with them about how else could we respond, how this issue of challenging behaviours in public housing. And having gone through the behavioural health needs assessment and having a better understanding of what the challenging behaviours needs were, unmet needs were in our buildings, we started developing what was eventually termed Housing Outreach Partners, or HOP for short. And I'm going to start using HOP because Housing Outreach Partners is just a very long term to have to use constantly. There essentially two, once we'd started talking about what the unmet needs were or how to address them, there were two elements which really stood out, and they were definitely quite different, but we didn't necessarily want to ascribe more importance to one than the other, in terms of exclusivity. The first one is outreach and engagement to unenrolled and underutilizing residents. And what I mean by that, or how we defined that in development, was creation of a cluster model to help build relationships between providers and residents. The use of our challenging behavior matrix, and utilization data from the data share, to prioritize outreach where it was most needed. This is to folks who were not already enrolled, or were enrolled and were not utilizing their services at an appropriate level, or indeed, folks who were, as far as we could tell, utilizing their behavioral health services, but were still experiencing some and creating some very challenging behaviors in the buildings where they live. And so we thought, sort of like having a team to do this kind of outreach with folks who were either unenrolled or underutilizing services would seem to be, a really good use of some time. The second element to it was that there are definitely some acute behaviors going on in SHA buildings, and sometimes we could not get an appropriate response to deal with it. As on the previous slide, we have things such as the designated crisis responders and the mobile crisis team, but sometimes they did not feel that it was appropriate for them to respond to what was an accelerating situation. So it hadn't reached a full crisis at that point in time, but nevertheless, for that particular person, things were going very badly, and very typically for the people around them, things were going very badly. And an example that I would use when we were having these conversations was there was a resident at one of our buildings who ripped out all of his wiring in his apartment and and this was in a building which is 17 floors high. He was taking to sleeping out on his balcony, and I used the term balcony rather liberally. This is a kind of a thing where people put plant pots typically, so it's about like 2 foot by 2 foot outside his window. Somehow he managed to get out there and was sleeping out there. but because he was not threatening to jump or anything else like that, he was not considered to be an imminent threat of harm to self or others. So it took a really long time to get someone to address this issue. And so this was one of the examples of, we could really do with something to address these acute but yet non-emergency, as far as the medical system was concerned, situations. So we kind of like mushed these two elements together: the outreach and engagement and need for rapid response to acute situations, and sort of like working with the folks from behavioral health and recovery division, kind of like developed a program, a pilot program. By this time, King County Housing Authority was also brought on board. And what came out of that initially was an RFP for a $2.2 million behavioral health program specifically to address these issues in the two housing authorities, which was fantastic. This was a great development, and we were super excited about this. The level of partnership between our agencies was humming along nicely. Of course, not everything will tend to go smoothly in these kind of situations, and so this RFP was put out there, and no one applied for it. I think this was quite a wake-up call to us, and without having asked all the agencies who could have applied for it why they didn't apply for this. I mean, some things were fairly evident. One of which is that the excuse me, the behavioral health integration that had just happened the earlier in the year was taking up a giant amount of bandwidth for the agencies. This was a very significant change for them. So, bringing out large new projects, was rather hopeful, I guess. So, and of course, maybe we had made things less attractive than they needed to be. So we did go back. We said we should give this another chance. So we did go back to the drawing board a little bit, just shuffled things around a bit, and before we re-released the RFP, I did a little bit more groundwork with some of the behavioral health agencies. I'd done some contacts with folks beforehand, and so I developed some relationships with some of the programmatic people in several agencies, and I had to talk to them, quite a bit about why this would be of value, and what a difference this could make to some of the folks who had the fewest advantages and least opportunities in our community. And basically said the housing authorities really want to support behavioral health agencies in this crossover, in this real understanding of the social determinants of health and how important they are. So the RFP was released a second time, and I am happy to say that we did have applicants, and ended up with Sound, who are the former Sound Mental Health, and it was particularly gratifying that they were the successful applicant, because not only had they been experiencing the behavioral health integration, which all of the agencies had been dealing with, they had also just gone through a pretty significant increase in their size as they merged with community psychiatric clinic, and that brought together into an agency which I mean, it was really a dream for certainly SHA to have them as a successful applicant, not least because 40% of the enrolled residents in behavioral health services were already clients of Sound / community psychiatric clinic. So that was during the summer of 2019, summer and autumn of 2019, that all that was happening. And then, of course, you know, we were waiting quite expectantly for things to happen. And of course, the landscape back at that point in time was less conducive to hiring. There were more opportunities. So sort of Sound was slowly developing its workforce towards the end of 2019 and the beginning of 2020. And then, of course, fairly early in 2020, everything changed again. COVID-19, as we all know, came about. So then the story became one about the value of rapidly adapting to a changed world. As I said, the original plan was this hybrid of outreach and engagement with folks who are not in any kind of acute situation, no emergency or whatever, and acute response to folks who were in you know, moving towards an emergency sort of situation, but not quite there yet. And how the outreach and engagement was supposed to happen, of course, was that the providers from Sound in the HOP team were going to be based in a cluster of our buildings, building relationships, waving to people, saying hi, meeting them, going to their apartments and chatting. And of course, none of that could happen once the reality of COVID-19 came in. So the very first action that was taken in terms of adaptation was that we had to say to those folks, well, we are developing a system of wellness calls for our most vulnerable residents, and we'd sort of like done some triage, and there were about 4,200 households with what we considered to be our most most vulnerable residents, most at-risk residents. And the folks from Sound jumped right into being a part of that wellness call system. And of course, with their level of skill and understanding of dealing with trauma and social isolation, they were very, very helpful at creating, you know, new relationships with residents, and just the idea of telehealth was certainly, you know, sort of like not new to them. At the same time, they, and we were very glad to see this, but they continued to agree to do face-to-face acute situation response. I mean, really, you can't, I mean, outreach and engagement is incredibly difficult to do, you know, remotely, but you just really can't do acute response without going face to face, and the folks from Sound were willing to do that, obviously with all the precautions that they could take. So for several 2 or 3 months, that's how they were operating, sort of this modified outreach with folks and actual face-to-face acute response. And that was working. And our property management were very pleased with the acute response section of things, it was very evident that they were going out and making a big difference to folks who were in crisis. And then just to make our lives a little bit more difficult, the financial impact of COVID-19 started to become very, very apparent to a number of different agencies, including King County. And at relatively short notice, they sent a notice out terminating funding for the entire program, effective June the 30th. And so, as you can imagine, that was a gigantic hit to us. I mean, certainly to us, and definitely to Sound, is an agency which had been persuaded to do this fairly significant project, and with fairly significant hiring implications, and they were then being told, and sort of they had funding, guaranteed for the entire year, and a presumption of funding for 2 years after that, because this was going to be partially funded for 3 years by mid King County funds. Only to be told after essentially 6 months that the funding was gone. This was really pretty tough. So here's the thing. I mean, we already had the issues, the pre-existing issues of behavioral health challenges before COVID. And then many people, many of you may have seen the Washington Department of Health's report on the, essentially a dire forecast for increased behavioral health issues coming as essentially as a second wave to the pandemic. Essentially, the problem is less related to the actual fear of COVID-19 itself, and more a behavioral health response to social isolation, and how that manifests, or how they have forecast it manifesting itself in Washington State, is a peak of behavioral health problems about 6 to 9 months after the initial impact of COVID-19's and the lockdown response. And so, in terms of the social isolation effects, how that manifests itself, or how they predict it will manifest itself, is with increased anxiety, increased depression, increased domestic violence, and increased suicidality. So these are all really very, very significant issues that, as a housing authority, we did not want to be finding ourselves in a situation where we had very limited access to behavioral health services. So once we heard that the funding, the King County funding, had been was going to be terminated, we, both SHA and King County Housing Authority, went into kind of a scramble mode to find out if there was some way that we could salvage the program through internal funding. Going back to the much earlier slide, we definitely have some people in both organizations, who have remnants of this idea that houses house, and find it quite difficult, the idea of spending fairly large amounts of money on social services, especially on new social services, in the situation where money is going to be looking tight anyway. But with the knowledge that property management had already been struggling with behavioral health, plus this really, as I said, dire forecast from the Department of Health, both agencies came up with an amount of money that was then proposed, or is being proposed to Sound to continue behavioral health services. And as part of this, it has been necessary to, in some ways, salvage the relationship with Sound itself. And when I say that, I go back to again the idea that sort of they're an agency that didn't have to apply for this. They thought that this was the right thing to be doing for our residents, and had the rug kind of pulled out from underneath them in terms of funding. So where we are right now is that we are still in negotiations about retaining that project. So this is where, as I said at the beginning, we've gone from a fairy tale into a drama. The negotiations, as I said, are ongoing, and I am fairly hopeful that we can avoid moving to that horror story / French farce stage of things. So yeah, future partnerships. And as I said, a lot of this has been based on the idea of partnerships. The housing authorities are not agencies who this comes naturally to. It's been a long struggle to get folk to be interested in social services at that deep level. It's not like they haven't been concerned about social services, but this is taking it to a new level. So going forward, it's been very clear, continues to be very clear, that creating and maintaining relationships with the behavioral health agencies themselves at that level is super important. Without having had those relationships, we wouldn't have had a partner in Housing Outreach Partners in the first place. It's also, because King County Behavioral Health and Recovery Division are the intermediaries between behavioral health services and the managed care organizations. They are a key element to the future of us working with behavioral health agencies. SHA has been fairly active with Healthier Here also, Healthier Here being the accountable community of health in the King County area. That has been able to provide some really helpful grant funding for a number of different services, and we have used to help kickstart foundational community supports with our residents, for instance. And at the end of the day, an additional partner who I think we definitely need to do more work with is at that higher level, with talking to the Washington state legislators, with the Healthcare Authority, with the managed care organizations regarding things like reimbursement rates. As I said earlier, the main reason why behavioral health agencies are not having their case managers go out into our communities for the most part is because they just don't get paid at a rate that allows that to happen. And that means that they aren't able to meet our residents where they are at. The situation remains that the behavioral health of our low-income residents is best served when providers meet them where they are at, and where they are at is often at home, not in the clinics. And so that is my presentation for now. I believe we have time for a Q&A if anybody has any questions. And somebody will probably have to unmute folks. I have not had a chance to look at the chat, so I don't know if there are questions. If somebody...
There really haven't been any questions posted in the chat, but if anybody has any, feel free to ask Andy anything that might come to mind. No? No questions at all? Don't forget, y'all guys are on mute, so if you are trying to ask, you have to unmute first.
Hi, I'd like to ask a question.
Yeah, hey, carry on.
I was wondering how you guys handle hoarders. We have a horrible time with hoarders and them fixing their deficiencies within the allotted amount of time, and it's hard to get any help for them.
Yeah, that is quite an issue, and hopefully nobody from SHA is here. Else, because I will definitely say that SHA has not been historically really effective at dealing with that. Like many other housing providers, hoarding has been seen as, you know, essentially a housing problem for us. And the one of the best things that we had come up with was essentially the what again some housing authorities have done, which is, you know, supporting folks by doing things like dig outs. That's not the correct term for them, but that's definitely how they were referred to. So basically, when someone is at the point at which you know they've been inspected and someone is saying we can't take this, either you clear this up or you know we'll have to start sort of like lease enforcement, serious lease enforcement. And of course one of the issues is that doing a dig out, while it is a short-term solution, it can get someone past an inspection, it is not a long-term solution at all. And it can be incredibly traumatic for the resident, who in many cases treasures the stuff that we might look at and think of as junk. This is often stuff that they've been developing for months, years, decades, a lifetime, and sort of we say, get all of that out of there. So you know, it is not effective to do that in the long term. So the hoarding project has, which used to, I mean, it still exists, has a great graphic, which is supported by the evidence that suggests that once you do something like a dig out, you know, within months, very typically, if you haven't done the support ahead of time and the continuing support afterwards, people fall back into exactly the same situation, and sometimes it makes it even worse, and the trauma for those residents is just added to. And the last thing we really want to do is not only be unsuccessful but re-traumatize folks. So basically the SHA is still in a developmental stage. We don't have the solution, because the solution it costs is quite costly. It's an ongoing service specifically to deal with hoarding. It's supporting someone. And in many cases it will require access to a particular kind of cognitive behavioral therapy for hoarding. So yeah, I mean that's the answer, is that you have to have, if you want to be successful and you don't want to traumatize your residents, you have to have someone essentially dedicated to providing ongoing support for people, to sort of support them through the process. And as they slowly decrease the amount of stuff that they have, that you keep holding their hand. And I'm not an executive producer of it, but there is an excellent movie that I recommend to anybody called Beyond Hoarding, to take a look at that, and how people, how some agencies have responded to that, and successes and failures along the way.
Yeah, it's really difficult because not only is it a mental issue, but it can also cause some health issues with stuff being stored against the wall and mold growing. And to try to explain this to somebody that is just thinking about their stuff is, I don't know. I'm just finding it very difficult to even get the proper help from like Frontier Behavioral Health or anywhere like that. We do the best we can, but we don't have a perfect setup yet.
Absolutely. Any other questions?
Well, this is Shar from Homes for Good, and I just wonder. I just think that I'm also on the Community Advisory Council for Pacific Source and Trillium, and I just think that that is a good funding, because a lot of times it's in our chips, and it's underutilized. I mean, we're all working together in Lane County. It's still, in the beginning stages, but getting it, the housing part and the behavioral health part on the chip, and somehow trying to put it together. And we are in the process of housing right now that is specifically for people with behavioral health issues, that has CCOs. It's going to have on-site health and behavioral health. And it took a lot. I mean, it was the county, it was the state, it was, the CCOs, other organizations that work with people. And how it came about was, it was the people who were utilizing the system with Medicaid to the point because they were homeless, or because they were getting evicted, or because they weren't getting the services they need. They overload the Medicaid system. And that's how we got the attention of it, to be able to get that help in. It doesn't really do a whole lot for people who are already in housing. It just offers an opportunity for people who need more social services that would be then where they live. Health and housing is my big thing, because I just really think that it goes together, and we don't want to evict people. We want them there. But again, I just think the CCOs, and I just wondered what you thought about that, as far as funding and, case management, or how we would get that into housing for, because it's always a money thing too, and a time. I don't know if I made sense, but.
Yeah, I'm probably not the best person to talk about the financial side of things. I don't know if there's someone else who can help answer that. Nope, I don't think I'm hearing anybody. Yeah, sorry, Char. I mean, sort of. I'd have to look into that a little bit more. I really am more of the sort of more nuts and bolts of the health side of things than the funding.
Right. There's just got to be. I mean, because what you're saying is so important, and it's so needed, and trying to figure out what avenues to go through to actually get it to happen for people, and get people to invest in it would be great.
Yeah, as I say, sort of our involvement with with our local accountable community of health, the Healthier Here, has, I mean, it's imperfect, but it's been a great way for there to be a forum for housing authorities and social service providers and the managed care organizations and the local governments as well. I guess my concern with our involvement with Healthier Here is that this is something that the smaller organizations have been clamoring for and are thirsty for more than the bigger organizations such as the managed care organizations are, and I think that's an issue that Healthier Here could address. I think a little bit more, is making sure that the managed care organizations are involved, because they have the purse strings for a lot of the important issues regarding social determinants of health. And I think that I've definitely heard of some very goodwill coming from some of the the ones involved in Washington State and in King County.
Thank you.
I have a question. What does the referral, like, can you walk us through what the referral process looks like? And does Sound provide like case management services on site?
Yeah. Right now, the referral system is relatively informal. And hopefully we are going to be changing that to make it slightly more formal in the future. I will say that again, in King County, and this is something that the Healthier Here, the Accountable Community of Health, is organizing, which I was a little bit skeptical about at first, but that I've come, COVID-19 has turned me into a convert for, is the Community Information Exchange, a platform that is being used. What is the name? Unitas is the platform that is being used for the King County Regional Community Information Exchange. And that is a system which is, essentially going to systematize our ability to not only send referrals, but to track responses to referrals to agencies such as Sound. COVID-19, and when I say COVID-19 has turned me into a convert, when we were doing these wellness calls, what we found is that, the calls themselves, of course, were developing or were recognizing the need out there. That was part of the point of the wellness calls, is to register what the need was and then be able to respond to it. And that included behavioral health issues such as depression and anxiety. What we determined from our typical informal form of referral is that, when you're sending out 150 referrals for people, if you don't have a way of tracking and knowing whether your social service partners have received this referral and have responded to this referral, then that, not only does the resident not necessarily have the services that you wanted or that they need, but it doubles up on the amount of work for us to say. We then have to call the agencies and say, did you get this referral? Have you done anything with this referral? So the great thing about the Community Information Exchange is that sort of like it will log that a referral has been received and that there is a way of getting response back from the agency that we send to. It's definitely way more systematic than what we've been doing in the past, which is secure email and or telephone calls. And in terms of in-person services, yes, as I said, Sound has been doing the acute situation response in person, using masks and trying to keep distance where they can. but they have been exposed, for instance, to folk who have had positive COVID-19, and so we have had a staff member or two have to go into quarantine after having exposure to that. Hopefully that answers the question.
There's a question here from Anna that says, what about RA pets or service animals when they are destroying the unit? In our when I did the behavioral health needs assessment, pets was one of the in the matrix. That was one of the columns that I put in there, and we actually did not get any reports of pets destroying things. There's been the occasional dog frightening folks, but yeah, no, I'm sorry. Yeah, I don't have a great response to that. Certainly in the past, when there's been, concerns about dangerous pets, is that we've been able to call in, our social service partners who've worked with animal control to sort of work on these kind of things. But yeah, strangely enough, hasn't been a big issue for us, even though, yeah, we have plenty of pets, and not everybody respects the idea that the dogs are only supposed to be so high. So